So this is the first adult program that I am facilitating. Thank you all for joining and being gentle. The rough order of events is going to be some welcome and introductions. That may be rather swift. We'll get into the presentation. We'll have plenty of time for question and answer. And at the close, I have just 2 brief polling questions to ask attendees. And for those of you who don't know, I am the new public services librarian for adult programs and communications, and that generally our library programs are in support of our mission to support all learners and make sure that everyone feels welcome. We'll include a wide spectrum of opinions and viewpoints, and of course, we don't necessarily endorse anything that is expressed. And we're always open to input and suggestions from the community. Dr. Anna Wald will be our speaker today, coming to us from the Seattle area. And you can see a full bio at the website listed here. Sorry, I just had a wacky thing happen on my end. There we go. Anna is actually Polish, and I doubt anyone knows what that Polish word under your name means, but the picture on the right is a clue. It's, how do you say it, Anna?
Pszczelarz.
It means beekeeper. And Anna kept bees at one point, and you now have mason bees, is that right?
Mason bees.
Mason bees. So Anna said to keep it short. So I'm just going to tell you that she is super qualified to be here. And actually, I would say, if you could say a few words about your background as well, that would be super. And then while you do that, I'm going to switch over to your slides.
Okay. So I work at, I'm on the faculty at the University of Washington. I'm a clinical virologist, and I spent several decades developing new antiviral agents and vaccines. Most of my work has been in the area of herpes viruses, but of course, in the last year and a half, I've become a coronavirus researcher as well, and been involved in both treatment, development of new therapies, as well as new vaccines for COVID. So I'm going to start, I'm going to talk about vaccines today, and depending on how many people are here and what questions are, I'm happy to talk about other COVID-related issues as well. But I do think that vaccines are sort of the most important issue to be talked about right now. Various slides come from lots of my colleagues, and you can see my disclosures, and I don't receive directly any funding from the companies that make COVID vaccines at this point. So can I have the next slide? So you probably have seen similar slides, but on the left, you can see the virus, which is really blown up, and all around on top of the virus, there are these little blebs, which are called the crown, and that's why it's called the coronavirus, because crown means corona. And if you really magnify one of those sections on the top of the virus, what you get is this spike protein. And it's oriented, so the green part that you can see on the top actually is what faces outward. And that's what attaches to human cells when it meets one. It attaches to the ACE2 receptor, which is one of the proteins that we have on our cells. Can I have the next slide? So here, what you can see again on the left is the coronavirus, and you can see the spike protein protruding from it. And now in pink at the very end of it, that's the portion that attaches. And on the right, you can see the human cell, and it has the receptor there that can potentially bind. Now, if you go to the next slide, you can see that when the binding occurs, that's when the virus can inject its genetic material into the human cell, and that it hijacks the human cell, and it basically makes it make baby viruses that then get spat out from that cell. However, if we have antibodies, which you can see here in green and purple, they attach to the spike protein and prevent that binding. And people thought very early on, based on work done with other coronaviruses, that probably a strong immune response to the spike protein that would prevent the binding is a key element to an effective immune response. Now, what vaccines do is the vaccines sort of train your body to recognize the bug when you actually encounter it in nature and get you ready for it. So instead of overwhelming your body and getting you either really sick or potentially, making you die, it actually, the vaccines make you make antibodies that then, when you encounter this bug, they attack the virus or the bacteria or the toxin and can bind it and can get rid of it so that it does not make you sick. So as you can see here, the antibodies will actually bind to the spike and prevent the attachment to the ACE2 receptor in the human cell. Can I have the next slide? What was called under the prior administration, Operation Warp Speed, actually wanted to develop 6 different vaccine platforms, 6 different vaccines, and use 3 separate platforms. Now, vaccines, there's various ways to make a vaccine construct. They decided to focus on 3 different ones. In case one didn't work, maybe another one would work for whatever reason. So number 1, which you can see here with the number 1, are the mRNA or the DNA vaccines. And both of the ones that we have are actually the mRNA vaccines. So these are vaccines in which the code for spike protein is put into an RNA, and the various companies have various approaches on how they do it. And then what they do is that they put it inside like a fat globule and they inject it. So those vaccines are incredibly straightforward. And they deliver the genetic code for your cells to make the spike protein. So then your cells, your muscle cells make the spike protein, express it on the cell surface. And I have another slide in a minute that'll come about that. And then you get an antibody response because your body can recognize it as a foreign protein. Number 2 are the viral vector vaccines. So that's the Johnson & Johnson vaccine, as well as the AstraZeneca vaccine. And these actually take a different virus, adenovirus, which causes the colds in people. They kind of cripple it in the lab, so it can't replicate. Then the adenovirus cannot cause the disease, but they insert the sequence for the spike protein into the virus. So then when that virus is injected into the arm, and it usually completes 1 cycle of replication, again, the spike protein is made, expressed on our human surfaces, and an antibody response results. The third way to make the vaccines is actually the traditional way that we have made vaccines for many years now, which is a protein-based. It's a traditional format. In some ways, it's the most conservative. And it turns out that it actually takes the longest to make and to do it right. So that's why the mRNA vaccines have been authorized first. Now we have one of the adenoviral vectors vaccines that also has been authorized. My understanding is that AstraZeneca has submitted to the FDA for the authorization. And the Novavax trial, which is the one that I'm involved in, we're still conducting the trial, though I think we should have results in another, I would guess, month or so. And then the 6th one is going to be Sanofi. That's going to be mostly done abroad because here you can't really do a placebo-controlled trial anymore. And that's also protein-based vaccines. So there are these various constructs that people are trying to develop in order to make sure both that we can make enough vaccines to meet the demand, but also just in case something didn't work with one of them, that there are other platforms that we can rely on. Can I have the next slide? Now, this is the first time mRNA vaccines have been broadly used in a community setting. So in that way, they're new, but actually scientists have been working with them in the laboratory for a couple of decades now. And if you can just sort of follow the numbers, which you see here, number 1 is in blue. That's the little code, genetic code in the RNA for the spike virus. And it's in this lipid, so fat globule, because then the cell, the muscle cell, makes it go inside it. And inside it goes to the ribosomes, which translate RNA into protein. And the protein, you can see all the way on the right, is number 8, gets expressed on the cell surface. And that stimulates an antibody response, as well as other immune cells as well to react, because this is not a human protein. So it knows that it's not self, and therefore it starts making a defense against it. Can I have the next slide? The way the vaccines are developed historically in this country has also been followed for these vaccines. So it all starts with an idea. And here the idea was that it's the spike protein that's going to evoke a response that's going to effectively block the infection. Then you do it in a test tube. So you do it in cells, and you show that if you have antibodies to spike that you can add, then cells can get infected. So that's the test tube trial. Then you do the trial in an animal, and then finally you move to humans. And human studies in general follow 3 phases, 1, 2, and 3. In phase 1, we ask, is it safe and what's the right dose? Number 2, we ask, does it result in the right immune response? And number 3, does it protect against disease? The FDA requirement for licensure is that it needs to be both safe and effective in order to be licensed. And the United States has actually the most stringent criteria for allowing things to go on the market. Can I have the next slide? So this is what a randomized double-blind phase 3 trial is. We take a group of people, we invite people in, and then we randomize. And it's double-blind because neither the person who's randomized nor the investigator know whether the person received the intervention, so the active vaccine versus control. And then we just let people run free, do whatever they do in their normal life. And when the infection rates are high, somebody's going to get infected, regardless of how careful they are. And it's really important that the study be blinded because people might change their behavior if they knew if they had the real vaccine versus placebo. So then we follow them for a while, and then we count how many cases we have to see whether the vaccine reduced the number of people that were infected. So that's sort of a schematic of a phase 3 trial, of which 4 of them have now been, the primary analysis have been done, and we're approaching for the 5th one for the Novavax. Can I have the next slide? So I wanted to go quickly just through the trials that have been done. So Pfizer, these are mRNA vaccines, both of them, Pfizer and Moderna. Pfizer enrolled 44,000 participants. It's a 2-dose schedule, 21 days apart. They started enrolling people 18, went up to 55, then went up all the way to 85. And then after that, they started going to 16 and 17-year-olds. Now, actually, they've also went down to 12. So now they have covered the whole spectrum, and they're looking to start at from about 2 years to the age 12. These studies were international, so there's a large population of people that were non-white in them. Pfizer enrolled at 155 sites. Enrollment was pretty rapid because people were desperate to get the vaccine. And now one of the questions is, when do you start counting the cases? Because you can't really biologically expect the vaccine to be doing its job until several days after the second shot. So here, for this one, Pfizer decided to start counting 7 days after the second dose. Moderna enrolled about 30,000 participants. They also have a 2-dose schedule, 28 days apart. So they took a slightly different tactic. They looked at people who are 18 or older. 37% of people they enrolled were minorities, 100 study locations, similar September to October for enrollment. And they started counting COVID-19 cases 14 days after second dose of the mRNA vaccine. Can I have the next one? So what were the results? Well, for Pfizer or BioNTech, that's the German company that they partnered with, In the primary analysis, there were 170 cases, 162 in placebo, and 8 cases in the vaccine arm. Okay, so we started with equal numbers in both groups, and those were the results. There were 10 people who developed severe disease after receiving even 1 dose. 9 of them were in placebo. 1 of them was in the vaccine arm. So the calculated vaccine efficacy is 95%. There's now an adolescent extension. I know some of you have youngish children. There were over 2,000 adolescents aged 12 to 15. And it turned out that in that group, there were 18 cases of COVID in the placebo and 0 in the vaccine. So for that group, the vaccine was 100%. Obviously, it's a much smaller group. So I'm sure at some point we will see breakthroughs. So approval for adolescents is anticipated this week. And as everybody knows, these vaccines are right now being used under emergency authorization, but the companies are asking for a full approval, and that's in process. In Moderna primary analysis, there were 196 cases, 185 in the placebo group, and 11 in the vaccine group. There were 30 cases that were severe, meaning that people were hospitalized or died, and they were all in placebo. For vaccine efficacy, it was very similar between the 2 studies. The trials in children are in progress, they've started, and they've also are asking for full approval. I think it's important to note that these companies, they obviously wanted an answer as soon as possible, but the whole study takes 2 years. For safety reasons. There's a follow-up for 2 years, and those people who are in the original study are still continuing in the trial. Can I have the next slide? This slide summarizes adverse events, so side effects of various vaccines. So in the first column, you have a whole bunch of common side effects, starting with local pain. Shingrix is a vaccine that prevents zoster. And it's given people over 50, and it has pretty bad side effects for a vaccine. The next one is Pfizer COVID vaccine that I just talked about. The next one is a flu vaccine that many people get annually. And then finally, in the last column is just salt water. And you can see that in every one of them, there's some proportion of people who will have side effects. So for an approved vaccine, such as Shingrix, overall, 38% of people complain of side effects. Pfizer vaccine, 26%, flu vaccine, 14%, and saline, 13%. So you can see that there's some differences between them. For example, local pain was most common among Pfizer. So 83% of people who received the Pfizer vaccine complain of pain in the arm. My arm also hurt after I got the Pfizer vaccine. It hurt for about 3 days. After the first dose, it didn't really hurt at all after the second dose. I don't know why, but that's what happened to me. I've heard a lot of people, it was the opposite. So I think it's very hard to predict. I think what's also interesting is that headache and fatigue are the most common side effects in everything, including getting salt water. That's because we're all very tired and we all have a lot of headaches. So that is probably not related, but that's why it's really important to look at this in the context of comparing it to placebo. Can I have the next slide? Now, the next vaccines that are going to be approved, or one of them already is, under the emergency authorization are the adenovirus vector vaccines. Johnson & Johnson enrolled 43,000 participants. It's a 1-dose vaccine. They enrolled both in the US and international sites. Short enrollment also. They started counting COVID 14 days after the dose. AstraZeneca, which is the last one to sort of end, 32 participants. And they did something interesting, which is 2-to-1 allocation. So if you participated in that study, 2 out of 3 people got the active vaccine and only 1/3 got the placebo. So that was to encourage people to participate at a time because they were still enrolling when Pfizer was becoming available. So they sort of wanted to make it more attractive. And actually Novavax did the same. AstraZeneca, 2-dose schedule, 21% minorities, 88 study locations. Enrollment started in August and ended in December. Can I have the next slide? These are the results. For Johnson & Johnson, the epidemic was raging at the time that they were counting cases. So they actually had 464 cases. And you can see that 348 of them were in the placebo arm and 116 were in the vaccine arm, for a vaccine efficacy of 67%. 67 is not 95, but it's a one shot, right? In terms of severe or critical illness, 60 in placebo, 14 in the vaccine. So it did substantially reduce the risk of very severe disease. And actually the efficacy for severe disease was almost 80%. So pretty effective to prevent you from dying from COVID. They looked at a whole bunch of subgroups in all of these studies, actually. So, diabetics, people who are thin, people who are not thin, people who are Black, people who are not Black, women, men, older, younger. Pretty much there were not huge differences between the groups. It looked like it works just about the same in every group that they have been able to look at. This vaccine is very important globally because it's easy to store and transport. So because of that, it is easy to take it to a place where we don't have easy refrigeration, such as sub-Saharan Africa or places in Latin America. Now, AstraZeneca, I have not seen the raw data. That's why I sort of graded out, but their press release. The other ones, I actually read the FDA summary, and that's where these numbers come from. For AstraZeneca, they reported in their press release that they had 190 cases. I don't know exactly how they were distributed, but they reported vaccine efficacy of 76%. They had 8 severe cases, all in placebo, and 100% prevention of severe and critical disease. Now, I think it's really important to mention that there are rare, very serious adverse events, so side effects that have happened with all of these vaccines. So first of all, with the mRNA vaccines, there have been cases of anaphylaxis, so severe allergic reactions. And I can talk a little bit more about them if anybody wants me to. It's about 1 per 300,000, but they've all been managed medically pretty well. And actually, it turns out that the part of the vaccine that people are allergic to is PEG, which is the same thing as Miralax, the laxative. So that sort of emulsifies the vaccine and makes it easier for the cells to pick up on it. And it turns out that some people are very allergic to that element. But it's a pretty benign compound. It's just some people are sensitized. The other side effect that has been seen with the mRNA vaccines, and it's rare, it's what we call ITP. So immune-mediated low platelet counts. And there was a well-known case of a physician in Florida who was very well reported in the press, who got the Pfizer vaccine and subsequently bled into his brain and died. On my floor at Harborview Medical Center, the janitor told me that when I asked him if he's getting vaccinated, he said he's not getting vaccinated because there was a physician in Florida who died after he got vaccinated. So people are really reading these reports and talking about it and making their conclusions. To my knowledge, there have been over 100 of those instances of very low platelets. Only one of them, however, was fatal. The other serious side effects of the adenovirus vector vaccines is this combination of both clotting and bleeding disorder that seem to be specific to the adenovirus. And that's actually why the rollout of Johnson & Johnson was paused. This is a weird side effect that's not very well understood. It seems to occur predominantly in women between the ages of 18 and 50 or 55. And the risk factors are very poorly characterized. It is also very unusual, so less than 1 per 100,000. But it's real, and I think it's something that people may want to consider when choosing which vaccine, assuming that they have a choice. Most people globally will not have a choice about which vaccine if they decide to have one. Can I have the next slide? I think one of the concerns was whether these vaccines will also prevent asymptomatic infection. So not just the disease, but they will actually reduce the amount of virus that you can get or prevent any virus from being in your nose, because if you don't have any virus in your nose, you can't spread it to others. So that's really important for herd immunity. And now there's emerging data that actually these vaccines are pretty effective at preventing asymptomatic infection, also in addition to preventing disease. I always thought infection is very important. Not everybody has though. So I'm very pleased to see this growing number of articles that show that these vaccines are effective in preventing infection because it means that they will stop the spread of the infection. Can I have the next slide? Now, I think it's important when we talk about vaccines is that the level of protection that we get from vaccines can be less than natural infection. Examples are mumps or pertussis, right? So whooping cough. The vaccine is just not that good. Vaccines can be similarly as good as natural infection, polio and measles. Or vaccines can actually be better than natural infection. HPV vaccine is an example of a vaccine that's really better than nature. Another example is tetanus. People who've had tetanus still need to get vaccinated because their bodies do not make an antibody response to tetanus, and you can have more than one tetanus episode. So that's really important to remember that just because somebody has had SARS-CoV-2 infection, it doesn't necessarily mean that they're protected. And it is also recommended that they're vaccinated. I think there's no rush for them to get vaccinated. I think obviously they're somewhat protected, but they're not as protected probably as somebody who's been vaccinated. Can I have the next slide? Now, one of the things that people have gotten upset about is that there are people who've been vaccinated, but they're still infected, right? And this is one of the headlines that just came out a few weeks ago. But it all depends how you look at it, because I actually get kind of excited when I hear a lot of people being infected, even though they're vaccinated, because if you look at the next slide, what it means is that there's lots and lots and lots of people being vaccinated, right? We know that the vaccine is 95% effective. So, and this is just the way the press can play it in a negative way. 102 people with COVID infections who are fully vaccinated, or 0.01%, which is obviously an incredibly low percent of vaccinated people test positive for COVID. The data in these two articles is exactly the same. So it all depends how you frame it. And the more people we vaccinate, the more cases there will be of people who are vaccinated and then have breakthrough infections. And that is to be anticipated. I think I'm done. So I'm happy to take questions. Thank you.
So we can do questions, I think, via the chat. So if you guys see your chat window on the right, there's a little chat icon. You can use that to write down any questions that you have. We don't have that many people, so I could probably just open it up verbally as well. So Laura and Emmy, if you have questions, feel free to unmute and ask your questions.
Hi, Dr. Wald. Thank you so very much for that succinct and really easy to understand presentation. I had a question related to the possibility of vaccinated individuals needing a booster, say, over time or annually, what that conversation is looking like among the experts.
Yeah, well, it's one of those things we don't necessarily agree on. So I think some people think that we will need annual boosters. Some people think that we need some boosters. I actually think that we're likely to need some boosters for these vaccines, but that eventually we will have a vaccine that will protect us against all of the strains. So the focus of these vaccines on the spike protein, I think, was the right way to approach it because we were in a pandemic and we needed a vaccine really, really fast. But chances are that if you add other proteins from the virus, like the nucleocapsid that changes less than the spike, then actually you might get an immune response that is broader and that will protect you from the other variants as well. Because then your body won't really care if you have a spike variant because it'll have an antibody against the nuclear protein. and it'll use that antibody to protect you, and it'll sort of ignore the spike. And there are now 4 papers, I think, showing that in animals, a vaccine that's only made to spike, not to nuclear protein, can protect you. So if I were to argue with somebody about this, and I do all the time, I think we'll have a vaccine. So we might need 1 or 2 boosts, but eventually we'll have a vaccine that will cover this virus much more broadly.
Oh, okay. Mm-hmm. Thank you.
We have a question that came in on chat. Is there any data on how long the antibodies are detectable after infection?
That's a really hard question to answer, because to really answer it scientifically, we need to follow people for a long time. And these people have been vaccinated, right? First people were vaccinated about a year ago. We know that the vaccines last for, the antibodies last for at least 6 months. Now, what happens with antibodies after the vaccine is that they normally fall, but if you encounter the bug, then they go up very rapidly. So what we don't yet know is what we call, what's the immune correlate of protection? How high do your antibodies need to be in order for you to be protected? We know it for some infections, but we don't know it for this one. I hope we'll know it by the end of this month. And I think then one approach would be that people could go and get their antibodies measured, right? And then we would know whether or not somebody needs a booster. So these data cannot be provided, though, until we have analysis of people who were vaccinated and failed. And we're looking to see whether there's a difference in antibody levels in people who had breakthrough infections versus people who did not. So that's what the ongoing work for the month of May. And the person who's leading that is actually here at Fred Hutch. And I email him about every other week asking him, when am I going to see the data? Because I'm very eager to see that. So I think once we see that, we'll have a lot more information about what number we should be looking for. And then it'll be much easier over time to follow people and have some confidence how long these vaccines can last. But please remember that for most infections, we vaccinate, we give somebody a series and then they're protected for life, right? For some of them, we give boosters every 10 years. So I do think that we can protect somebody for a very long time with these vaccines.
And I have a related question to the testing thing. It's the PCR testing is rather confusing. They talk about how many cycles they do for the testing and so on. And there was some testing going on 40 cycles or more. And then now I think I just saw something on CDC that they're saying they recommend testing vaccinated people at 28 cycles. Now, can you talk about the PCR testing and how many cycles is reasonable to test for viable transmissible virus?
So the problem is, the answer is we don't know. So everything's a guess. Now, people make this assumption that if you can grow it in culture, then it's infectious to people. And if you can't, then it might not be. Now, on the average, I think that's probably right. A cell culture in a laboratory, it's not the same as a person-to-person transmission. So personally, and this is something, again, that people have various views of, I don't like saying that this is a level, and if there's less virus than 28 at 28 cycles, then we don't think it's infectious. Because probably most time that it's more virus, it's also not infectious, right? We just don't know that number with this great certainty. But basically, the number reflects how many times it has to be amplified, right? So the more times you have to repeat the reaction, so the higher the number, the less the virus to be able to detect it. 40 is usually the limit of detection. So, and people who are acutely infected and who are ill, we'll see numbers in the 18 or 20, and that's worrisome. That's a lot of virus present. There are some PCR methods that more directly measure the amount of the virus. And actually this virus, there's a lot of it in people who are infected. It's like 10 to the 8th, viral particles per swab, which is a huge number. Does that help at all? Put it in context?
Yeah, it is. It's just, I know that there's all this conversation about how much it takes, like you said, to be viable to actually be able to transmit. And I thought Dr. Fauci was saying something about it. I forget what number he was using. because above that number is not going to be anything that's viable to actually be able to infect a person. And that was similar to what you're
probably right.
Yeah.
You know, but these numbers are always derived, and we don't directly know what number that is.
Unless there's somebody else, I have another question that's sort of in, which I don't really understand very well, is the vaccine adverse effect recording system or something like that.
Yeah, the VAERS.
Yeah, the VAERS system. And so can you comment first of all on how that works and then second thing is versus reported and unreported cases and so on. And it's kind of, it seems a little vague. And then the second part of the question is just about how these vaccines compare to previous vaccines in history, you know, in the 70s, 80s, and 90s of the United States and to each other.
So if you remember, the VAERS is an internet-dependent system, right? So 70s, we didn't have internet, so we didn't have VAERS, right? So the systems for recording adverse events were different. So VAERS is just one of the data safety monitoring systems, and it's a system designed on purpose so that physicians can report side effects, but also people can report their own side effects. So physicians actually by law are obliged to report to VAERS, but anyone can get online and just fill out the form. You know, I had the vaccine and then I had a really terrible headache, or I went to the emergency room, or I had a rash, whatever you want. And then if, excuse me for a second, my puppy is barking. Come here, love.
The joy of Zoom. Welcome.
Yeah, I've seen a few places where they have animals across the screen in these some of these Zoom things, and then so it's like a competition who can bring their pet into the into the picture. We even had job interviews doing that with people.
Oh, wow. I see John is joining us. John, if you can hear me, you can ask questions via the chat or verbally, and Anna's back.
Sorry about that.
That's okay.
So anybody can report to VAERS, and then if the event is serious, then the CDC actually, there are people that monitor those reports, and they reach back and they verify and validate what's been reported. One of the issues in the past with VAERS is that there have been several documented instances of people making up side effects and reporting them. So for example, right now in VAERS, apparently there are several reports of bad things happening to kids that have been vaccinated under EUA. Now, kids can't be vaccinated yet under an EUA. So something's wrong with this picture, right? So then the CDC like goes in and they clean it up, basically. But they do make sure that they can count things that are reported, because that represents a really sensitive way of picking up early problems. And there was just a very nice study showing the safety of the vaccine in pregnant women. And that was actually based partly on the VAERS data. So that's what it is. But you can go in and you can look at it, and anybody can pull data from it. You just have to sort of know how to interpret it. So that's one system. The other ways that people are monitoring safety is in health maintenance organizations that have electronic medical records. So they have not only the good numerator of what happens to people, but they also have a much better denominator. Problem with VAERS is the denominator is not very good.
Yeah, that was my follow-up, was just like, it must be then difficult to compare each vaccine against the others, because you have to make sure that the data are valid, right?
Right. So they validate the data and they know how many vaccines have been given out. So there have been some interesting, there have been some good HPV vaccine safety data that's been published using that. So it's a useful system.
Hello, I had a quick question for you. Thank you so much for your wonderful presentation. And I was like a tad bit late, so I don't know if you went over this yet, but I'm a teacher and I'm kind of curious about the future of vaccination in terms of children, and sort of what that might potentially look like in the next year or two?
So vaccines for children are right now in the process of being tested. In the children aged 12 to 18, I think probably the Pfizer vaccine will be approved this week for that age group. So teenagers will be able to get vaccinated very soon. And then younger age group, those kids are being enrolled. I think every company is going to have studies on kids, but it's going to take a while before we can use them. So I anticipate probably in September we'll be vaccinated kids age 2 to 12. I was hoping earlier that we can do it before the school year starts, but at this point, I don't know that that will happen.
Thank you. Wonderful.
And I think I should add that, I think kids are actually really important for herd immunity. I don't think we can really call a community immune before the kids are vaccinated. So they're a really important part of all of this.
Looks like John's having a hard time with his audio. John, if you can hear me and you want to put a question out there, you can use the chat window. Are there any other questions? Holly, Phil, Rhett, Laura, Emmy. I have, so if someone is naturally good at producing antibodies for the coronavirus and they get the vaccine, how does that impact them? Or does it? Does it change anything about how their body responds?
You mean they were infected and they made the antibodies?
I guess that's what I'm saying. If someone were to be infected and their body responded in such a way that they created antibodies and all was well, if that kind of person gets a vaccine, does that impact, change, alter somehow how their body will react once they are infected?
Yeah, so I think, that's one of the reasons that people who had the infection don't want to be vaccinated, because they say their body already made natural antibodies. And the problem really is that in general, for coronavirus infections, our antibodies do not last. So besides SARS-CoV-2, there are 4 other species of coronaviruses that normally circulate and cause common colds. And we know that people can get infected with those viruses over and over again because our antibody response is not very strong. Probably because mostly it's an infection in your nose and respiratory tree, not everywhere. And partly because, the viruses are smart and they figured out how to evade your immunity so they can infect you over and over again, right? So the question here is, will the infection protect you as well as the vaccine? We have extraordinarily effective vaccines, 95%. And thus far, the data I've seen on how well a natural infection protects you is about 80%. So, it's okay. It's like the AstraZeneca vaccine, but it's not 95%. So that's why the recommendation at this point is even for people who've been infected to still get vaccinated. Now, it may be that in another year, we'll know a lot more and we'll be giving those people only 1 vaccine and not 2. But right now, the recommendation is still to get 2. That's where we are with knowing about it.
Thank you. How are we doing? Let's see if John managed to get in. Oh, he did. Welcome, John.
John.
Yeah, I don't see any messages. John, if you're on and you have any questions, please feel free to chime in.
Oh, I had one more question.
Yep.
Please.
Dr. Wald, can you talk a little bit about the difference between a live vaccine? Is that what's called a DNA, and then the mRNA type of vaccine, which is what, these are?
So we don't use a lot of live vaccines. None of these, I guess I wouldn't really characterize the adenovirus vaccines are live either, because that virus cannot really replicate. So the live vaccines that we use are the vaccines that were developed a long time ago in the 50s and in the 60s, because the way they were developed, that was before we understood about DNA structure, right? And were able to manipulate a genetic material, is that they were passaged. So they were grown in a culture, and then there were the ones that survived were put yet in a different test tube, and they were passaged sometimes hundreds of times over and over again, usually with cells that were not human. So they were adapted to cells that were somewhat different than human cells. And that weakened the virus, because the virus otherwise naturally was adapted to infect us and to cause disease in us. But it got adapted to a different species or to different types of cells, and it weakened the virus, or what we call attenuated. Because of that, it was then made into a vaccine, and that was a live virus vaccine. So it could actually multiply in a person, but not cause disease. So your measles, your mumps, your rubella, your chickenpox, those are all vaccines that are made from live weakened viruses. Mm-hmm. Really, all of the other vaccines, or most of the other vaccines, are either protein-based or are recombinant. So use molecular biology for their construction. So the adenovirus vaccines, I don't know that I would call them live, because the adenovirus has been so crippled that it doesn't really replicate. It's a replication incompetent virus when it's given to you.
Thank you.
Mm-hmm.
I have one more question.
Yes, please.
Okay. I also work at a school, but in a more administrative role, and I am anticipating that we'll see some hesitancy, vaccine hesitancy around children getting immunized when that becomes available for schools. And I'm just curious, what your thoughts are on that, and what maybe some, science-based response can be to, whatever we can do as a community to sort of provide information in a way that doesn't get, it's a sensitive topic, and mm-hmm. Certainly here on Orcas it is. So, just anticipating having those conversations in our community, friends, professionally, and navigating that.
Yeah, I think you're absolutely right. I think we'll be having a lot of those conversations. I think, with every month we have more information about these vaccines, right? So the sort of safety database and people's confidence in general has been shown to increase. I do agree with you that I think getting to vaccinate the children will be yet another big step for many parents. But there are also parents who are very eager to vaccinate their kids. Now, more than 250 children have died from COVID-19 in this country, and that is substantially more than die every year of influenza. Mm-hmm. And childhood vaccine for influenza is recommended on an annual basis because of over 100 deaths each year. There's about 150 or so each year. So now we're dealing with a disease that's clearly more deadly than that. So I think that's some of the facts. Mm-hmm. Vaccines in general are very safe. And the reason the vaccines in general are very safe is because we give vaccines to people that are healthy. So the barrier for showing that they're safe is much higher than it is for a drug that you give for an illness. Okay. So there's a huge investment, and we want to really make sure that kids are given vaccines that are, only safe. And most childhood vaccines are incredibly safe. Mm-hmm. So I think between time and, hopefully statistics, many people will be convinced. And then also setting an example, people who have kids, vaccinating them, saying, look, I vaccinated my kids. Anecdotes are very powerful. And my kids are vaccinated, I can tell you, but they're all over 18 now, the youngest one, so.
So I have two more questions. One is, I've heard people say, or I've heard out in the ether, people say, the vaccine will sterilize you. So I have no idea where that comes from.
I do.
Okay.
It's a very interesting story. It's obviously not true. There's a short piece of the viral sequence that is very similar to a sequence of a protein in the placenta. So there's this myth that antibody to the virus will also result in antibody to the placenta and inability to get pregnant, or immune response against the placenta. So a couple issues with this. First of all, that string, that code is much too short to result in an immune response that's really meaningful. So that's one issue. The other issue is, which is sort of interesting, is that placenta actually has a lot of virus material in it. So in general, our DNA is about 8% viral DNA. We have assimilated viruses throughout our evolution into our DNA and are using them for various purposes. And placenta especially is good at that. So there are a lot of those in the placenta. And maybe that's why that protein in the placenta is actually derived from a very old virus that has been in our body for millions of years. But the other important piece is that it's clearly not true, because people have gotten pregnant after having COVID. And if vaccine was sterilizing, then the COVID should as well, right? And people have also gotten pregnant with the vaccine. In fact, I have a close colleague who was sort of asking me, how long do you think I should wait to get pregnant after my second dose? And I don't think she waited even a couple of weeks. So, people, it is not a good approach to birth control, let's just say.
Fair enough. The next question is there a role for CRISPR in COVID-19 vaccine development or anything else?
Maybe. I don't know what that would be. So
I guess in some kind of a therapy to avoid infection. I don't know enough about CRISPR to even begin to know how to answer that question.
Right. I'm afraid I'm in the same boat.
Fair enough. Any other questions? Let me check the chat. Let's see any chat. Well, we're at the top of the hour, and unless there are questions, then I feel like we should let you go have your evening, Anna. I am going to launch a quick poll. So this is like a new thing. It's super quick, and dang it, it's not working.
So I will sign off. Thank you, everybody, for having me. And
thank you, Anna.
Thank you.
I'll see you around East Town or wherever.
Excellent. Thank you, Anna.